Good afternoon. Coming into the home stretch here, kind of. You have a few more minutes to, actually have a little bit more than that, to fill out some blue papers if you are going to win that fabulous prize of a one-year subscription to Emergency Medical Abstracts. Who knows the second prize? 2 years, right, okay. And if you don't have a blue sheet, just put it on one of these out here. Stuff the ballot box. You can put as many bad questions as you want there. More increase your chance of winning. Lower extremity DVTs is what this 30 minutes is about. This is everything that you need to know or want to know in 30 minutes. The DVT decision is pretty easy compared to the going down the pathway for the pulmonary embolism. The pulmonary embolism thing is tough. It's expensive. It's got a fair amount of risk to it. The consequences, if you don't make the diagnosis, are pretty substantial. That's harder. This is a lot easier. Question is what tests, what's the risks, those kinds of things. We're going to talk about the role of clinical suspicion, D-dimers, ultrasound, some therapeutic issues, and lastly about distal clots in the calves and what ought to be done with those, if anybody can resolve that. So this part starts out, this chapter says clinical risk stratification is important. We'd like to scratch that word out and put down it's essential, because you have to kind of rate the likelihood of this person having a clot in their leg to go down the diagnostic pathways. Collectively, when physicians are asked, what do you think the risk is of this person having a DVT, a group of physicians, they're really good. They are at least as good as the Wells rules or other kinds of rules in picking out who's likely to have a DVT or not when you have a group of physicians. However, it kind of breaks down when you start looking at any one individual physician's ability to make that decision. And that's one of the reasons people like to use the Wells rules or the Geneva rules or the Charlotte rules or those kinds of things, because they have been looked at, validated, and we try to make them as much as black and white, non-judgmental as possible to can more consistently say on an individual doctor basis, their judgment may vary. Some may be excellent, some may be poor, but if you apply the Wells rules, doctors are generally shown to be pretty good at that across the board. The Wells rules, you can't remember these things. There's a problem. How can you work with rules that you can't remember? So if you can't remember them, and if you do, even if you do remember them, there's one rule, there's one of these components here that is very subjective. And even if you come up with somebody who's determined to be low risk on the Wells rules, that doesn't mean no risk. And so I'll show you some stats on that. But anyway, this is an excuse for having one of those ectopic brains like PEPID or something else, so that you can access the Wells rules when you need to, or access rules for a PE when you need to. Because I think I'll show you that you have to make some decisions about what's the likelihood before you start ordering tests in these cases. As an example, if somebody has a high probability for having a blood clot in their leg, you ought not order a D-dimer. You ought not order it. The reason you ought not order it is what happens if it comes back negative? Does it change your mind about anything? No, because you already determined this person has a high likelihood of a clot, so that test isn't going to help you. There's, on the other side of the equation, what if you determine this person has a really low likelihood of having a clot? In that case, a D-dimer will end the workup if it is negative. Low likelihood of having a clot, D-dimer is negative, workup is over. They don't even get an ultrasound. It doesn't happen. At least theoretically, that's what the papers say to do. So I think the Wells rules are in your book here, yes? The last one is the one that's a problem. All of these are pretty straightforward, give you a point or two. But the last one, an alternative diagnosis is as likely or more possible than than a DVT. It requires a lot of judgment. An alternative diagnosis is more likely to be the case than a DVT. If you decide that, you subtract 2 points from this thing, It's probably the major discriminant in the entire Wells rules. That's why people would prefer to use other rules that are much more black and white and don't involve any judgment. So abstract 2, it gets to the point that says the Wells rules are better than individual physician judgment. So here you go, 54 studies, a meta-analysis of 54 studies. The Wells rules are more reliable for proximal versus DVT and better than individual physician judgments. The individual physician judgment, the confidence intervals are very large. So when you take all of those doctors together, they do a great job. When you take them one at a time, confidence intervals are wide. So one individual doctor could be great, another individual doctor could be terrible. On average, they're quite good. So the question then comes up, you've done some risk stratification, hopefully using some kind of objective measures if you can. And the question comes up now, what's the role of the D-dimer now? Clinical risk stratification didn't cost you a nickel. D-dimer doesn't cost very much. Ultrasound, which would make the elect up, is more costly. And then venography still remains kind of like the gold standard. I'll show you tests that use venography as the gold standard. So just to reiterate, if you determine that it is high risk, you go right on to an ultrasound, don't bother with the D-dimer. So where does the D-dimer fit in? The D-dimer fits in one spot, depending on what kind of D-dimer it is, the low-risk patients. Low-risk patients who have an ELISA D-dimer or a latex agglutination D-dimer, low risk, add in the negative D-dimer, the workup is done. The likelihood of those people having a clot in the next 3 months is around 1 or 1.5%. You're never going to get better than that. Now, some of the papers say, depending on what D-dimer you use, if you have a moderate likelihood of having clot on the Wells criteria, and you use the ELISA D-dimer, not the latex agglutination, the ELISA one is the better one, that would exclude needing to do anything further as well. Now, not everybody agrees with that, but most people do. But so hopefully you're going to be either at one end or the other, and you're not going to be in the middle. So it points out, even in paper number 1, there was a high percentage of people who had low probability of having a clot. There was 12% of the patients in the study were low probability. And then when they added in these negative D-dimer, the risk was 5 cases out of 222. 1.75% is the risk of you missing a clot in somebody over the next 3 months who came in with some leg. So that's the number you're dealing with. You're going to miss 1.5%. Paper number 3 found a 1.6 incidence of DVT in the 35% of patients who were low risk by the Wells criteria and a negative D-dimer. So the bottom line is only patients with a low clinical probability of DVT and the Wells by Wells are candidates for especially latex agglutination D-dimers. 4 is a Wells paper. New England Journal confirms that if you have a low probability and a negative D-dimer, the workup is over. Their miss rate was 1%, as initially determined then on 3-month follow-up. All these papers that look at, did you make the diagnosis, follow these people for 3 months and decide if they get a clot in that 3-month period, you probably had it before. That might be an overread of it, but that's what they decide. Let's skip to number 6. 1,075 patients suspected with DVT. They used the Wells rules and the simpler red, which is a latex agglutination, a good latex agglutination test, of 882 patients with low risk and a negative D-dimer. Now look at the numbers. There was 1,000 people studied, and 882 of them were considered to be low risk. The majority of the patients are considered low risk. And if they had a negative D-dimer in this study, 1% had on 3-month follow-up a DVT. So all the papers, it's 1 or 1.5%, that's it. And these are huge studies, 1,075 people suspected DVT. In this study, 4.5% of the low-risk patients had a DVT without doing any kind of D-dimer test. So 4.5% of people had a DVT. So if you decide that somebody is in the low-risk criteria, you've already excluded 96% of the people as having a likelihood for a clot there. And that number comes up over and over again. Even in the worst studies, the low-risk people, the risk of them having a clot is maybe the highest number you're going to see is like 12%. 4% is on the low side, 12% is on the high side. Once you determine clinically you're in the low-risk group. So then you throw onto those people a D-dimer, which turns out to be negative, and you go from 4% down to 1%, 12% down to 1%. So you add on these together, and that's basically what paper number 6 says. So the question is, are you convinced? The data is pretty compelling. Number 5 is a systematic review of 12 trials involving 5,400 souls. The 3-month cumulative incidence of DVT was 0.5% in those having a latex agglutination, simpler red test, and a low-risk stratification. So that's the lowest, 0.5, 1, 1.5, that's it. So the average may be around 1%. In this paper, with these 5,000, in this analysis of 12 trials with the 5,000 people, they said, let's take the people of moderate risk on Wells and use a really good D-dimer test. We're going to use the ELISA D-dimer test on those. How many of those people who had moderate risk on Wells and a negative ELISA had a blood clot in their legs on 3-month follow-up? 0.4%. Wow, pretty impressive. Now you need to know what kind of ELISA or whether you have a latex agglutination or ELISA. This is pretty compelling. It says even moderate risk cases can be excluded if they have a really good an ELISA D-dimer. And if you have low risk patients, a so-so test like the latex agglutination D-dimer, the workup is over. Now the question is how many of you do that? Because my sense is that most people who are kind of being thought of as having a blood clot in their leg, they just go right to doing the ultrasound, and they may throw in a D-dimer or not, but they're going to go right to doing the ultrasound. And they say, well, it's not a very expensive test. It's generally a pretty good test. But what the heck happens if you have a false positive? Can you have a false positive ultrasound test? You bet your booties you can. And now what have you done, Ollie? Because you had plenty of information to exclude them right from the get-go. Low risk, negative D-dimer, and then you threw in this other test that turns out to be falsely positive, and you have conflicting data now. These tests say it's negative, this test says it's positive. You need a tiebreaker. Next, we're going to do a venogram because of the potential for a false positive to occur. So the literature is pretty compelling. You can stop, and you probably should stop, with low risk, latex agglutination negative, done. Moderate risk, ELISA, done. Abstract number 7 stresses the importance of clinical risk stratification and why not to go, and tells you why not to do a D-dimer directly. So here's 73 people with a negative ELISA D-dimer, and 12 of them had a venous thromboembolic event, and 5 of them had distal leg clots. So these people had false positive D-dimers. They had a false negative. They had a D-dimer that was negative, yet they were, of these 73 souls, 12 of them ultimately had clots. So that's kind of why you need to do clinical stratification. The characteristics in the 12 people who had false negative D-dimer tests, well, a duration of symptom exceeding 2 weeks, previous anticoagulation, the presence of distal deep vein thrombosis, only that, and lastly, a high clinical probability of clots based on application of the Wells criteria. So here you go. Here's people who have high probability of having a clot by Wells, and the D-dimer turns out to be falsely negative because they had this clot. So you get a negative D-dimer, and you have a high risk stratification saying you got a clot. So you have data that is conflicting. One piece of data says no clot, other piece of data says high risk of clot. You basically need a tie-breaking test. You can do an ultrasound in those cases, because you have to acknowledge that there are going to be false negative D-dimers, which will mislead you. You can't say, well, this piece of information is much more important than that piece of information. The clinical risk stratification will generally exclude 95% of the people who have clots. So that's a good piece of information. D-dimer generally works quite well at excluding clots. But if they don't agree, you just can't say, well, I'm going to pick that one as the right answer. You can't do that. How good is ultrasound in making the diagnosis of a DVT? 8 and 9 are both important papers. They talk about duplex, meaning two kinds of things. One is this compression component, where you're trying to occlude a vein, and if it has a clot in it, by pressing, you can't occlude it, and then the Doppler part is measuring blood flow, with the colors and that kind of thing. And they basically say, 8 and 9, in symptomatic legs, duplex ultrasound has a 95 to 100% sensitivity. Symptomatic legs, my leg's swollen, my leg's hurting. Specificity, excellent. 97 to 100% specificity. Looks really, really good. Positive predictive value of ultrasound, 97%. Negative predictive value says that you don't have a clot is 98%. 98% negative predictive value of a ultrasound is the same number that you will get if you have a low-risk clinical stratification and a negative D-dimer. Negative D-dimer and a low-risk clinical stratification, at most, 2% of those people will have a clot. And this says ultrasound will be wrong 2% of the time. 2% of the time, if it says it's negative. So the fact is that both of these are equivalent. One is not better. Taking those two elements together is equivalent to an ultrasound in terms of its negative predictive value. What about number 8? Using venography as the standard, 12 of 160 acutely ill patients with asymptomatic clots were looked at. Because the question here is, how accurate is this scanning in asymptomatic legs versus symptomatic legs? Asymptomatic legs, we're concerned about, well, maybe you're thinking about a PE in somebody and you want to scan their legs, but in fact their legs are fine, they don't have any symptoms, their legs are not swollen, but you're looking for clots. So there's a distinction here between whether ultrasound is good in asymptomatic legs or compared to symptomatic legs. Well, the first one is, number 8, using venography as a standard, 12 of 160 acutely ill patients had asymptomatic clots. 12 of 160 sick patients had clots that were asymptomatic using venography. 5 of them were proximal, and ultrasound missed 2 of them. Ultrasound missed 2 out of 5 clots in an asymptomatic leg that was demonstrated on a venography. 7 of these 12 patients had the clots distal, down in the calf. Ultrasound missed 5 of the 7. So ultrasound is not nearly as good in picking up clots in people who have asymptomatic legs. When you're just trolling to find, I wonder if you got a clot because I think you may have a pulmonary embolism. So ultrasound is not nearly as good in asymptomatic people. Now, you're not going to be doing a whole bunch of studies on asymptomatic people doing venography. Venography has a 5% incidence of causing phlebitis. So the idea of doing studies with an invasive test like venography in asymptomatic legs, hard to get that through the IRB kind of thing. The next one is also an interesting paper. It's 130 legs of post-orthopedic surgery patients and 72 legs of patients symptomatic for DVT. And they had both ultrasound and contrast venography. So here's another study. You had your knee surgery and you're lying in the bed and somebody's going to come in and do a venogram on you. 130 people had their legs, had venography that were asymptomatic. Again, that's kind of like a little risky there. What did they find out? They found out some nasty stuff. In the post-operative orthopedic patients, venography was positive for calf vein DVT in 20% of the cases and 30% of the symptomatic leg cases. So people laying in bed after the orthopedic surgery, 20% of them, if you do a venogram, will have a clot in their calves. That's why there's such a big push to make sure the orthopedists down the room are really trying to prevent any clots in association with their patients being in bed thereafter.
Were these patients receiving DVT prophylaxis?
Well, that's a good question. Does it say very much about that at all in the abstract? And can you tell me what year that paper was? Because I don't have the name. 96, old. Because they're beating these orthopedists over the head now, probably because of this data. This paper, if they did not have DVT, 20% of them have calf vein, and they're asymptomatic, just laying in bed after their orthopedic surgery. So they want to get the stockings on people. They want to give them the low molecular weight heparin on these people. The issue is how long do they get it after they have their knee replacement or their hip replacement? Because of numbers like these that are kind of frightening. So we basically pointed out that in these orthopedic patients lying in bed who were asymptomatic, 20% of them had clots in their calves. Sonography was then done, and it was 92% sensitive, missed 8% in the post-operative group, and it missed 14% of the clots in the symptomatic patient group. So we're talking about wasn't very good for calf vein problems. So the conclusion here is ultrasound will miss 8% of calf vein DVTs in post-op patients, but more importantly, it'll miss 14% in symptomatic cases. Paper number 13 says it'll miss up to 36% in cases where you're trying to find whether you have a clot in the calf or not. So it's not as nearly reliable in these cases, unfortunately. So the question will be, do we need to make the diagnosis of a clot in the calf? Because some people say, even if you have it, don't treat it, which we'll get to in a second. What about the strategy of treating people before you've really made the diagnosis? Is the strategy of DVT treatment prior to ultrasonography reasonable? Paper 10 and 11 both defend this position. So you have somebody comes in at 9 o'clock at night, you think they have a DVT. It means that you have to call the ultrasonographer in from 45 miles away kind of thing to do it. Can you just say, here's a shot of low molecular weight heparin, we'll do it in the morning? And both 10 and 11 both say, yes, you can. What are the potential downsides here? Are you likely to bleed, or what's the risk of bleeding for one shot of low molecular weight heparin? Well, it's got to be considered to be extraordinarily rare. But if it happens, you're going to say, well, why did you give it, doc? Can't you make the diagnosis yes or no and then give the treatment? So it's going to be a little bit hard to defend, but statistically speaking, ultrasonographers are one of the hardest techs that you can find in a hospital. And then the issue is heparin-induced thrombocytopenia. You know, one shot of low molecular weight heparin is going to be associated with that? Certainly not. The incidence for people who are getting heparin for some protracted period is probably less than 1%. It is overstated in terms of the risk. Some people say it's 3 or 4%. It's less. So the downside is pretty small. And papers 10 and 11 said, yeah, we got away with it. 10 is 530 Italians, got low molecular weight heparin, followed by a DVT workup in the next 15 hours. No major bleeding occurred. Number 11, 128 Canadians. You have to remember, can you extrapolate Canadians to the rest of the population, you know? They got low molecular weight heparin and returned the following day for their testing. None of these people had indications for hospitalization clinically, by the way. And in this study of the Canadians, 74 of the Canadians who were being evaluated for DVTs, 35 of the 74 were positive. They had it. And 54 of the Canadians were being evaluated for PEs. And they said, well, come on in back in the morning. We'll check you out for your PEs. And 9 of them had it. But they gave them the treatment anyway. So the treatment is low molecular heparin, whether you have it or not. So, and there are a substantial subset of people who have DVTs who probably have minimally symptomatic or asymptomatic PEs anyway. As I mentioned yesterday, the study where they did lung scans and people who only had DVTs, half of them were a high probability for PEs, asymptomatic. So this says you can do that. Anybody here do that? Get your shot and see you in the morning kind of thing? Oh, a lot of people. So this would be viewed as community practice. It's not kind of a wacko thing where somebody's suggesting not to call the ultrasound tech in. The next question is, what What if you still believe that the patient has a high likelihood for a DVT despite a negative ultrasound? Well, remember, you can get a false negative ultrasound, so you have two choices. Number 12 talks about the two options in patients with a negative ultrasound, who you think, man, I'm really sure that that's it. You can do a D-dimer. And normally you would not have even done a D-dimer in these cases because you're going directly to ultrasound because you're so convinced that it's likely to be there, and you do the study and it turns out to be negative. So holy smokes, I wasn't expecting that. Do a D-dimer, the D-dimer turns out to be negative. Wow, negative D-dimer and a negative ultrasound, it's pretty likely that that's not a clot there despite your belief that it is. So you have, and the other choice is to repeat the ultrasound of the leg in a week, kind of thing. I think it's negative. I think they say it's negative. I think it's positive. Let's recheck it a little bit later. So they did 408 patients, and they randomized them to one of the two techniques. All of these people were thought to have a high likelihood of having a DVT. DVTs were diagnosed in 4.7% using the D-dimer venography standard that I didn't mention. So what happens if you have a high probability of having a DVT clinically? Ultrasound is negative. Now what? And then you do the D-dimer, and the D-dimer comes back positive. Well, I would say, okay, fine. We get a positive D-dimer. I think it's high clinical probability. You're not going to start them on this dangerous therapy of warfarin for months and months without definitively knowing. So they said, okay, in these cases, go ahead and do a venogram. So basically, there's still places for venograms to be done to separate these tie-breaking cases here. So that was one of the strategies. Do a venogram if the D-dimer is positive in somebody who has a high probability clinical and a negative ultrasound report from the radiologist. The other option is just repeat the ultrasound. Don't treat them, just repeat the ultrasound in a week. So they did compare those two, 408 people. DVTs were diagnosed in 4.7% using the D-dimer venography strategy and 0.7% in those getting repeated ultrasounds. They said these were not statistically significantly different, 4.7 and 7%, but it sounds to me like one is better than the other, and you will also know the answer right away rather than waiting for a week. So I would tend to personally favor get the ultrasound. It's negative. I'm going to get the D-dimer. D-dimer is positive. I'm going to do a venogram because I really believe that you have a clot in your leg. What's the role of MRI in this thing? Any radiology-related people in this room here? You know, I personally believe that when they get better MRI machines, they're going to replace the CAT scan machines because there's no radiation associated with them. And now they have these 3 and 6 Tesla magnet kind of things. We started off with a half Tesla magnet. That's probably like a Tom Thumb kind of thing in terms of its capacity, but they're getting bigger, bigger, bigger. Now they're talking about using MRIs for evaluation of pregnant women's abdominal pain kind of thing because no radiation. Looking at appendicitis with MRI in women. And so maybe 5 years from now, 6 years from now, we got really, really cool MRI machines. CAT scan will be like a thing of the past. It will be like the ultrasounds.
They still take half an hour.
They take time, but they're going to be basically faster, yes, just like the CAT scans are faster. Sometimes having a test that's real fast is kind of bad because then our threshold for doing it becomes quicker, lower. And that was a story with the head CTs in kids. Now we can do head CTs in kids without sedating them. And sedating them was a hassle. Now we don't have to sedate them because you got fast CAT scan machine. So we lighten up a lot more kids. So this paper number 13 says, it's a 14-study meta-analysis using contrast venography as the gold standard, which I think most people would agree is the gold standard. And they basically said the pooled estimate for sensitivity of all of these studies was 92%. Well, ultrasound is a little bit better than that, maybe a 95%, 96%, but this is pooled. So it's not quite as good, but it's pretty impressive. 91% sensitivity for picking up the diagnosis of a clot in your leg. Specificity, 95%. You're not going to get much better than that. I mean, no, you know, ultrasound, CAT scan may be, ultrasound may be a little bit better. And when you separate it out into proximal DVT versus distal DVT, the sensitivity for proximal DVT was 94% with the pooled results of the MRI. That's pretty good now. We're getting real good because everybody knows the calves are not as good. And so when they looked at the calves, the sensitivity for the calves was 62%. Calves are 20% of the clots in your legs are going to be in your calf. The other 80% are going to be in your thigh and higher. So pooling all the results is kind of a little misleading. If you're looking at how good is an MRI for your thigh, it's quite good. And I'd said 94% sensitivity. Not so good in your calf, but neither is the other studies, 62%. The problem with this paper is, and they say it at the end there, is the range of sensitivities was so large that although they pooled the results and got some good numbers, individual studies were all over the dartboard. And so they said, we're not really ready for prime time yet, and interpret these results with caution. And the last two papers are making the case for and against, or against and for, treating calf DVT. And the 14 that makes the case for not diagnosing it and not treating it. And they basically say that serial exams of compression ultrasonography show extensions from the calf proximal in between 1% and 6% of the cases. They say, yes, you know, it has been reported that proximal extension can occur between 0 and 44%. 0 and 44% is a huge variable range, but they said, if you look at serial scans, with compression ultrasonography, the numbers are small. It's in the neighborhood of 6% would maybe be the upper limit. And so number one, the extension risk is relatively small. The pooled risk for thromboembolism going to your lungs, even if you extend, they say, is 0.6% at 3 months in patients with serially negative ultrasounds. So that allows you to develop that strategy that says, okay, you've got a DVT in your calf. We're not going to do anything about it. We're just going to do serial ultrasounds. And if we find that it moves to your thigh, then we'll initiate treatment. They also talk about a 5% rate of false positive distal compression ultrasonography, 5% false positives. So you think you have it, but you really don't. And now we're going to initiate treatment, which people may consider a little dangerous. And what's the risk of bleeding from anticoagulation? Well, they say the risk for a major bleed associated with anticoagulation is between 0.6 and 1.2%. I have another paper that says the risk of major bleeding from anticoagulation is 1% per year, but you're not going to be anticoagulated for a year, and so this number sounds to be high. I think 1% a year for major bleeds on anticoagulation, those are all the people with atrial fibrillation who are taking this stuff till they drop kind of thing. That number is not inconsequential. So they say the risk of movement is small. You can check it periodically by doing ultrasounds once a week to see whether, in fact, that has occurred. There is the potential for a falsely positive ultrasound in your calf, and you might not even have it there in the first place, and that there is some risk associated with this treatment. It is not particularly benign. The next one is the case for treating it. They say the rate of distal for proximal extension is in the neighborhood of 10%. So they're saying the number's a little higher than what we said in the other paper. They said the max was like 6%, but they're in the ballpark. We don't know how to identify the subset that will propagate. It's postulated that anticoagulation using their calculations may benefit 10 to 20% of people with distal DVTs. That's the best case that you can make, that you may benefit 10 to 20%, but they're not focusing on downside associated with taking anticoagulants. What if you're in a car wreck and you're on warfarin? I don't know that you're going to do so good, kind of thing. So how many of you are in an environment where somebody has a calf vein DVT, they are treated with anticoagulants? Can we see what the community practice is? Stony Brook treats them, calf vein DVT. And your place treats them? Anybody else treats them? Come on, we're all friends here. There's another one back there. So, and let's go the other way. How many actively do not treat the calf vein DVTs? So it appears that community practice is not to treat them and taking the more conservative view. Now, if I were to ask you about that, do you do serial ultrasounds to see where that thing is, kind of thing, every once a week, and to keep your fingers crossed that it is still has not migrated? Statistics on migration are, it says it won't. It won't. 90% of the time, it won't. So hopefully that's enough of DVTs.
Is one follow-up ultrasound scan enough?
Is
doing one ultrasound scan a week later enough?
Oh, you mean how many weeks do you continue to do this? Well, I think it's one of those things where it kind of gets asymptotically, the value goes down substantially week after week after week. So, but I don't know that anybody's ever done a study that says, are we going to do it for 1 week, or are we going to do it for 2 weeks, we're going to do it for 3 weeks in this situation. But if you haven't had a problem by 1 or 2 in terms of extensions, you got to think that the 3rd week, nothing's going to be happening there, kind of thing. So how many ultrasounds are you aware of people doing in these cases? 1 or 2 or 3? 1? Or couple, okay.
I had a sobering case the other week.
A sobering case.
Very sobering, yeah. A lady came in with a 6500 D-dimer, and she'd been seen by a colleague the week before, and she had calf DVTs. So he rightly so sent her home and had her follow up. So I saw her last week, and I ultrasounded her legs again. The clots hadn't moved, but the D-dimer frightened me. But her pulse ox was normal. Her EKG, she wasn't in a sinus attack or anything. Her lungs were full of clots. Now go figure.
The lungs were full of clots, and somebody who was a calf or leg?
Calf, it was just calf, and it hadn't propagated.
And it hadn't propagated as best it could be determined by ultrasound.
That's right.
And she was full of clots.
Her lungs, and she was asymptomatic.
Asymptomatic, full of clots.
Not short of breath,
Very high D-dimer.
very high D-dimer. That frightened me, the D-dimer.
That is a sobering case. Just forget what I just said in the last half hour. They'll do what?
He'll actively treat them if it looks like it's. The ultrasonographers will give you some ideas so they think it's actively extending and growing.
Let me tell you what I would do. If it was me, I'd treat myself.